Hello, I'm Dr. Charles Pollack, an emergency physician at the Sidney Kimmel Medical College and Thomas Jefferson University in Philadelphia. I'd like to welcome you to this educational activity on the current and emerging methods to reverse anticoagulation with the direct-acting oral anticoagulants, or DOACs.
The following audio is part of a certified educational activity titled Reversal of Action, Addressing the Unmet Need for Universal Antidotes to Factor Xa Anticoagulants. Access the entire activity and complete the post-test at www.peerview.com/NKJ. Downloadable slides and practice aids are also available.
Let's look at a patient, a 67-year-old male who presents with ongoing bright red hematemesis. We learned that he takes apixaban 5 milligrams twice daily for atrial fibrillation, and we don't know when he took his last dose. He has melena per rectum, so obviously the bleeding's been going on for a while, but there's no history of prior GI bleed. He gets a liter of saline rapidly in the emergency department, and after that his blood pressure is 93/67, and blood for transfusion will be available from the blood bank in about 15 minutes. How would you manage this patient? Oral anticoagulants are widely used to reduce the risk of thromboembolic events in patients with atrial fibrillation, and DOACs are also used in venous thromboembolic disease treatment and prevention. This class of drugs has gained a lot of acceptance due in part to its favorable safety, efficacy, and ease of use profiles compared with warfarin, which for decades was our only option. The problem, of course, is anticoagulation with any agent does increase the risk of bleeding over a patient who's not anticoagulated. Each time a patient is placed on anticoagulation therapy, for example, for atrial fibrillation, stroke prevention, or to treat or prevent venous thromboembolism, we need to make a specific patient-directed risk-benefit assessment to make sure that we're comfortable that the benefit of anticoagulation exceeds the risk of bleeding. If we look at the overall experience with the DOACs, you see a general benefit compared to warfarin with major bleeding profiles. This is particularly pronounced with apixaban in Aristotle and with the lower dose of edoxaban in Engage. At the bottom of the graph, you see a meta-analysis line of all of those studies put together, and in general, you're seeing a bleeding profile that looks better for the DOACs than it does for warfarin. This is particularly true for intracranial bleeding, in which the DOACs as a class reduce the risk of intracranial bleeding compared to warfarin in patients being treated for atrial fibrillation by about 2/3. Again, the issue may arise even in properly treated, properly dosed anticoagulated patients. Most of the time, particularly with the DOACs, bleeding events are minor and self-limited. But if patients come in with a more significant bleed or with some sort of hemodynamic compromise, then a good ready resource to consult while managing that patient is an American College of Cardiology consensus recommendation published in 2017. We're going to show you bits and pieces of that on the slides. But basically, the types of factors that contribute to the concept that the patient may need to be reversed or repleted, and we'll talk about the difference between those two as we go along, are issues like whether the bleeding is at a critical site, especially the brain, if there's hemodynamic instability that's not readily corrected with supportive care, or if there's clinically overt bleeding and the patient is rapidly losing his red cell parameters and you know that things are going to be worse. That's a major bleed, and that's a patient who may well need to be considered as a potential candidate for reversal or repletion. Fortunately, these major bleeds are unusual, but when they do occur, a ready reference for helping you manage these complicated patients is provided by this ACC consensus document. Here you see a rather complex chart looking at the evaluation and treatment for critical site bleeds. In the leftmost column, you see the types of critical site bleeds: intracranial and other CNS bleeds, pericardial bleeds, bleeds around the airway, bleeds into the thoracic cavity and the abdominal cavity, and extremity bleeds where you can have to worry about intramuscular hemorrhage that can lead to compartment syndrome or intra-articular bleeding. And you see in the middle column some of the initial signs and symptoms that would clue you in that this is going on, but these are not subtle presentations. Typically you'll know even before you get in the room what's going on with these patients. The potential consequences of the bleed are in the far right column, and that's really the justification for considering repletion or reversal in these patients, because these are patients who literally have life or limb at risk. Now, our sample patient here had a GI bleed, And it turns out that as dramatic as intracranial bleeds are, GI bleeds are the most common severe hemorrhagic complications of treatment with DOACs. They're rarely fatal, but they're associated with a lot of morbidity with high resource consumption. Patients stay in the ICU for a while, they get scoped, they tend to get lots of transfusions, and so we want to be able to manage them efficiently and expeditiously. It's always good to have a stat GI consult when you're evaluating these patients, deciding whether and how to intervene, but we realize that that some of you work in situations where you don't have a gastroenterologist readily available to you, so you may be making the decision yourself whether or not to reverse or replete. The important thing to remember in GI bleed cases is if you choose to reverse or replete, remember that's not a hemostatic maneuver. What you're doing is relieving iatrogenic coagulopathy, but you're not necessarily stopping bleeding. You're not plugging holes when you give more factor concentrates or when you reverse the effect of a medication on factor concentrates. So people are often hesitant to do this, and we wonder, should we order coagulation tests first? The problem with that is that the typical coagulation tests aren't particularly helpful. With dabigatran, if you have a sensitive assay, the activated partial thromboplastin time may be helpful, but what you really need for a quantitative assessment of dabigatran-related anticoagulation is a dilute thrombin time or an eccrine clotting time, most of which are simply not available in the U.S. With apixaban, edoxaban, or rivaroxaban, there are specialized anti-10A chromogenic assays, which are great if you have them. The typical anti-10A assays are not calibrated to the oral anticoagulants, so if you have one in your lab that's calibrated to enoxaparin, for example, that's not going to help you. If you do have a stat turnaround test, an anti-10A assay for one of the DOACs, then that would be helpful, but again, most of you won't have that. What you do have is a thrombin time, an APTT, a PT, and INR. And for the patient who's being managed with a non-vitamin K antagonist oral anticoagulant, these are not particularly helpful. There's been a lot written about this. There are some tests on the horizon for a quicker and clearer assay of dabigatran and anti-10A coagulation levels, but they're not ready yet. So for the most part, you're going to be using clinical judgment about whether to reverse or replete these patients. So let's look at the current state of bleeding management and DOAC reversal. Remember our patient, 67-year-old male, ongoing bright red hematemesis. He's on apixaban, he's got melena. The question is, would you reverse the apixaban? And then the really important question to follow is, if so, how are you going to do it? Anticoagulation reversal, or repletion, which we'll talk about as well, is a significant intervention for a physician to undertake. Again, most of the time, oral anticoagulant-related bleeding, including warfarin-related bleeding, doesn't require reversal or repletion. But when you do, you're going to be going beyond supportive care. Now, supportive care in this vein means really intensive stuff sometimes, transfusion, invasive procedures, mechanical ventilation, endoscopy, but that's all short of reversal. Why don't we reverse more often? Well, because remember, the patient is anticoagulated for a reason, either because they have high stroke risk from atrial fibrillation, or because they've recently experienced or you're trying to prevent a venous thromboembolic episode. If you reverse or replete, to remove the protection the patient has against thrombotic consequences, then that patient is very quickly back at an at-risk state, which you or your colleague thought in the past needed treatment. So we'd like to avoid that if we can. So if we're going to reverse, and we'll talk about repletion separately, if we're going to reverse an oral anticoagulant, what type of properties would we like to see in the reversal agent? If we could design an ideal reversal agent, it would specifically target only the NOAC the patient's taking. It would act immediately. It would completely reverse the agent in question. It would provide a sustained effect so that we can then take care of the patient who's no longer coagulopathic. It would have very predictable effects. It would have no procoagulant or antithrombotic effect itself. And it would be easy to use. I like to say that it would be like a code drug, because as an emergency physician, if I'm going to reverse somebody, this is something I want to pull out of the SureMed or the code cart and immediately give the patient and know that I'm reversing the anticoagulant in question. Remember, the goal of reversal is not to stop bleeding. It's to remove the effect of the anticoagulant so that then I can move forward with other maneuvers, whether they're physical or pharmacologic or surgical, to stop the bleeding in a patient who's no longer coagulopathic. So if you have a reversal agent, whether it's ideal or not, when would you consider using it? Well, again, let's consult the 2017 American College of Cardiology Expert Consensus Decision Pathway. If the bleed is at a critical site, or if it's life-threatening, and remember, those two are not mutually exclusive. A GI bleed can be life-threatening even though it's not technically a critical site. The first thing, the obvious thing, is to stop the oral anticoagulant. Secondly, if the patient is taking warfarin, and only if the patient is taking warfarin, give 5 to 10 milligrams of IV vitamin K. Do not give vitamin K to a patient who's taking a DOAC. Why do you give vitamin K to a patient taking warfarin? Well, remember how warfarin works. A patient in steady state on warfarin has no functional coagulation factors 2, 7, 9, and 10 because those are the so-called vitamin K dependent factors. Body can't make those if the patient is taking warfarin. So if you give vitamin K, you're not reversing warfarin. The only thing you're doing is allowing the patient's liver to start making those vitamin K dependent factors again. It can take hours to days to restore normal levels of those factors. So it's an important step in the warfarin-treated patient, but it's not a reversal step. You want to do all of the usual supportive and abortive issues that can stop the bleeding, whether it's manual compression or clamp or supportive care with transfusion, fluids, pressors if needed. Look for antiplatelet agents. Remember, a lot of patients who are taking an anticoagulant may also be taking aspirin or a P2Y12 inhibitor, so be sure that those are stopped as well. And then look for comorbidities that could contribute to bleeding. For example, if the patient's thrombocytopenic, you might need to give platelets. If the patient's uremic, if the patient has liver disease, there could be other factor deficiencies that go beyond what the oral anticoagulant is causing. There may be a surgical or procedural approach to the bleeding site. And then in this mix, if you have it available, is a reversal or a repletion agent. Now, in managing a patient like this who has a life-threatening GI bleed while taking apixaban, we have a new option. Recently approved was a specific reversal agent for factor Xa inhibitors called Andexanet alfa. This works rapidly and specifically to reverse the effects of both direct and indirect factor Xa inhibitors, so it should be useful in these unusual bad bleeding situations. This drug has just been approved. The bolus is either 400 or 800 milligrams, and the infusion is 4 milligrams per minute or 8 milligrams per minute. You should check the package insert, but it starts with a bolus and then is followed by an infusion that goes at 2 hours or longer. It is basically a decoy factor Xa. It's an inactivated Xa that will attract and bind to, in a competitive fashion, the factor Xa inhibitors that are being given to the patient. But this is not an agent that contributes to the coagulation cascade. So it pulls the Xa inhibitor off of native Xa, ties it up with this decoy, and that way the patient's own Xa can once again substantively participate in the coagulation cascade and restore hemostasis as long as the Andexanet alpha levels are high enough. The pivotal study, the equivalent of reverse AD for Andexanet alpha, is Annexa-4. Annexa-4 is looking at patients who are taking 10As who have acute major bleeding. There's an emphasis on intracranial bleeds, and these are patients who are known to have a certain time of ingestion since their last dose. And that's important because that helps determine the dose of Andexanet that's given. The efficacy outcomes are changes in anti-factor Xa activity and clinical hemostatic efficacy through 12 hours. One of the important differences that distinguishes Annexa-4 from reverse AD is that in intracranial bleed patients enrolled in Annexa-4, there's a mandated follow-up CT scan so you can look at hematoma progression. That's very useful to have. The safety measurements are looking at thrombotic events, are looking at 30-day mortality, and they're looking at the development of antibodies to factor 10, factor Xa, and to the Andexanet. Patients are given a bolus plus a 2-hour infusion in the Annexa-4 protocol, and the dose is different depending on which anti-10A they're taking and how long it's been since they took their last dose. The bolus is either 400 or 800 milligrams, and the infusion is 4 milligrams per minute or 8 milligrams per minute. Emergency physicians, if they don't have a reliable history of when the patient took their last dose, are probably going to default to the higher dose. Now, this is a drug that comes as a lyophilized powder. It has to be reconstituted prior to infusion. And so you need to think a little bit ahead when you're going to use this drug, because you don't just pull it right off the shelf and inject it. It's got to be reconstituted first. This is the design and analysis plan for the Annexa-4 study. They looked at both the safety and an efficacy population, which are defined the way you would expect them to be. And I'm going to run through for you now data from an interim analysis that was presented at the American College of Cardiology meeting in March of 2018 that included all patients enrolled as of October 20th, 2017. And again, at the time we're taping this, the Annexa-4 study is still ongoing. This assessment of clinical hemostatic efficacy, which was much more rigorous than it was in reverse AD for Idarucizumab, is described here. This is methodology that came from Cerroti's study of 4-factor prothrombic complex concentrate and warfarin-related bleeding, and so it's a validated approach. So these are baseline characteristics from the interim analysis in the safety population, 227 patients. And you see, again, the likelihood of patients having a bleed on these pretty safe agents, in this case the anti-10A anticoagulants, is much higher in older patients with comorbidities. So there's a very disproportionate share of patients enrolled in Annexa-4, in this case, who have atrial fibrillation, 78% or so. Medical history is complicated. Again, older patients with AFib tend to have that. There's no surprise. And the median time from presentation until Andexanet was given is somewhere in the neighborhood of 5 hours. And so you can see it took a little while from these patients after presentation for the decision to be made to reverse them. In terms of the qualifying bleed, about 60% of these patients had intracranial bleeds, or a little under a third were GI bleeds, and the remaining 10 to 12% were other bleeding sites. Again, this is reflective of the types of trouble that patients with AFib get into when they're taking anticoagulants. Again, the good news is this is rare. Most bleeding events associated with 10A anticoagulants are self-limited and respond to supportive therapy only. So I'm going to show you a couple of slides here, again from the interim analysis of Annexa-4 presented in March of 2018. In this case, it's rivaroxaban. On the y-axis is anti-factor 10A activity. Again, this is specific to rivaroxaban. On the x-axis is time. And you see that the columns here are baseline, so that's prior to Andexanet administration. The second from the left is the end of that Andexanet bolus. The third is going to be 2 hours later at the end of the infusion. And then you see 4 hours, 8 hours, and 12 hours. And what you see there from the Boston whiskers is a nice quick response, seeing the anti-factor 10A activity diminish very quickly when the infusion is given, as long as it's given. But then remember that this is a competitive blockade, so once you turn that infusion off, the patient's going to pretty rapidly return to wherever they would have been anyway had you not reversed them. So this is, again, a little different from the Idarucizumab approach for patients taking dabigatran. You can't mix and match these. You're only going to use Idarucizumab if the patient's taking dabigatran. You're only going to use Andexanet alfa if the patient's taking an anti-10A, like in this case, rivaroxaban. So same general concept of reversal, but different ways of administering and then managing the patients thereafter. Here's the same data for a slightly larger group of patients who were taking apixaban, but you see the same sort of response. Give the bolus, anti-10A activity drops way down. Continue the infusion, it stays down. Turn off the infusion, goes back up again. So if you can manage the patient's bleeding problem in that couple of hours while the patient's on the infusion, you're not fighting against an iatrogenic coagulopathy. A much smaller group of patients treated with enoxaparin. Remember, this is an indirect 10A inhibitor. And you see the same effects, albeit with a smaller sample size. So remember, one of the endpoints is effective hemostasis at 12 hours after reversal, after Andexanet. Of 132 major bleeds that were adjudicated, 109 achieved excellent or good hemostasis, which is an 83% rate. 95% confidence intervals around that, 76 to 89%. So very effective. Remembering that hemostasis is not just dependent on reversal with Andexanet, it's also dependent on other treatment. Here's some subsets. This is an interim analysis, so don't read too much into this except for the obvious thing, which is all the data are on the right side of the line of unity. So no matter which issues the patient has, there's a favorable effect for Andexanet towards good or excellent hemostasis. So very compelling story here. On the safety side, thrombotic events occurred within 3 days of Andexanet, so that's very early. So it's like immediate post-reversal thrombosis in 6 patients, which is 2.6%. By 30 days and 11%. So higher than we saw with Idarucizumab. Again, most of these events occurred in patients who had not yet been restarted on any sort of antithrombotic therapy, much less therapeutic anticoagulation. And so that puts it back on us. The physicians who reverse these patients need to think about when the patient should be restarted on the protection that was prescribed for them in the first place. 30-day mortality rate was 12%. 11 of those 12 are cardiovascular. But remember, this study had a pronounced, deliberate shift towards intracranial hemorrhage for enrollment. These Kaplan-Meier curves show thrombotic events on the left, all events on the right, events after restart of anticoagulation. On the right, the blue line is lower, smaller, because once you restart anticoagulation, you're less likely to have a thrombotic event. But the point here is, when you reverse a patient who's anticoagulated, whether you do it with prothrombic complex concentrate, with Idarucizumab, or the Andexanet alfa, as soon as the patient's stable, as soon as you can, you should be restarting anticoagulation. Now, in the case of an intracranial bleed, that should be done in consultation with neurologists and neurosurgeons. GI bleed in consultation with gastroenterologists. You don't make this decision just, oh, they're reversed, they're stable, let's restart them. But the point is, restart patients as soon as you can after the event to give them the protection that you know they needed in the first place. So this is a complex but important table that looks at the thrombosis and mortality rates in bleeding patients, so this would be only group A of reverse AD, who were either reversed or repleted for acute bleeding related to an oral anticoagulant. The top line there in the pink color is Annexa 4, and you see thrombotic event rate overall is about 11%, and the intracranial hemorrhage population about 12%, mortality 12%. In reverse AD, group A only, the patients treated with Idarucizumab, you see about a 5% 30-day thrombotic rate, 6% among those who had an intracranial hemorrhage, and mortality a little higher than you see in Annexa 4, 14 to 15%. SOROTI is the study I mentioned earlier, which was the qualifying study for 4-factor PCC compared to warfarin, and you see that not all of the same endpoints were reported, but the mortality rate was lower. These patients may have been less sick to begin with, so it's hard to tell. The fact of the matter is, you need to be aware of the fact that these are sick patients by definition. If you've got somebody taking an anticoagulant that you feel clinically needs reversal, that's a patient who already has a high mortality risk. The post-reversal or post-repletion thrombotic risk is in large part up to you. You need to get that patient protected as soon as possible. Now, there is one other drug we should discuss, albeit briefly, another complex name, in this case Seraparantag. This is a drug that is currently in phase 2 study, and it's being done for the most part sort of under the radar, so we don't have a whole lot of information about it. There was a letter to the editor published in the New England Journal that described some phase 2 work with Idarucizumab. This drug, though, supposedly has, by different mechanisms of action, affinities for heparins, including low molecular heparin, 10A inhibitors, and 2A inhibitors. So in that situation where I, as an emergency physician, know I have an anticoagulated patient, but the records aren't complete, I don't know what anticoagulant they're taking. I can check an INR and know whether they're taking warfarin. If it's not elevated, then I know the patient's taking some other anticoagulant. This could be helpful, but we don't know how far off the market this is, if it'll ever come to market. What we do know from the small phase 2 study is that looking at a number of different hemostatic endpoints, that there was benefit to Seraparantag. It's safe and well tolerated from what we can tell, but it's just too early to know whether this will have any clinical utility in the future. So in conclusion, remember, it's fortunate that the majority of patients taking a DOAC are never going to be candidates for reversal or repletion. In those rare situations where this occurs, severe, life-threatening, ongoing bleeding or bleeding into a critical site, keep in mind that there's this ready resource from the American College of Cardiology, published in 2017, an expert consensus decision pathway that's, I think, a good reference to have available. Andexanet alfa has been shown to rapidly reverse anti-factor Xa activity. The interim results looked really good. The FDA approved it based on those results while waiting for the final results. This is, I think, the best way to manage patients currently who meet those rare criteria for the need for reversal while taking a 10A. Seraparantag may or may not at some point be available. That would be potentially a reversal agent for 10As and 2As. But what if our patient with the GI bleed was taking dabigatran, the only orally available direct thrombin inhibitor? How would you manage that patient? Well, according to the ACC guidelines, consistent with FDA and EMA labels, you would, if you felt the patient needed to be reversed, use Idarucizumab. Idarucizumab is a Fab fragment antibody that is a specific reversal agent for dabigatran. The dose is 5 grams. That's not a misprint. It's not 5 milligrams. It's 5 grams of a monoclonal antibody. That's a big dose. If for some reason Idarucizumab is not available, then you can go back to the repletion approach. And again, a patient who's recently taken a dose of dabigatran should be given charcoal and hopefully bind up some of that before it gets absorbed. But meanwhile, you've got a drug that is very efficient and very effective at reversing the anticoagulative activity of dabigatran. Idarucizumab, as I mentioned, is a humanized Fab fragment antibody. It binds both free dabigatran and dabigatran bound to thrombin, which means that it literally pulls dabigatran off of thrombin and pulls it out of the tissues. It has no known off-target effects. It doesn't reverse heparin or other anticoagulants. Its binding affinity for dabigatran is about 350 times that of dabigatran for thrombin, and that's why it can be so effective. The dose has to be big, though, because there's a 1-to-1 stoichiometry between Idarucizumab and dabigatran. And so to bind each tiny little molecule of dabigatran, you need this big molecule of Idarucizumab, and that's why 5 grams is the appropriate dose. Drugs given IV, there's an immediate onset of action. It has a short half-life, which means you can restart anticoagulation fairly soon after you reversed. And it has no intrinsic procoagulant or anticoagulant activity. Idarucizumab came to market through an international study called REVERSE-AD, meaning the reversal of active dabigatran. Not a huge study, 503 dabigatran-treated patients who were deemed clinically to need reversal. And they could get there one of 2 ways. They were called Group A if they were taking dabigatran and presented with uncontrolled bleeding that the treating clinician, independent of any lab values, felt needed to be reversed. Or they could come in under Group B if they weren't bleeding, but they were taking dabigatran and they need some sort of sharp procedure, whether it's catheter-based or in the operating room, that could not be delayed until the dabigatran effect wore off. So about 2/3 of patients went into Group A, the bleeders, 1/3 went into Group B. After that, they were all treated the same. They all got 5 grams of Idarucizumab. The primary endpoint was a biochemical endpoint. As you might imagine, these are almost all AFib patients. A lot of comorbidities, a lot of variation among the Group A and Group B patients, some bleeding, some not. Some had GI bleeds, some had intracranial bleeds, some were trauma victims, some were just headed to the OR. It was impossible to come up with a single clinical endpoint that made sense for powering a study. So instead, we looked at what Idarucizumab is supposed to do, and that is it is supposed to reverse the anticoagulant effect of dabigatran. So the primary endpoint was the maximum reversal of dabigatran within 4 hours of the administration of Idarucizumab, as based on one of 2 studies, eccrine clotting time and dilute thrombin time, both in a reference lab, both linearly related to dabigatran concentrations across a broad range. So REVERSE-AD actually studied the extent of reversal of dabigatran. And then, of course, there were secondary outcomes that looked at when the bleeding stopped, how the bleeding stopped, whether surgery was required, whether there was good perioperative hemostasis. And there were also other secondary endpoints of interest, such as post-reversal thrombotic events, mortality, other lab tests, and then at 90 days, the development or not of anti-drug antibodies. You see here the patient demographics of those 503 patients enrolled in REVERSE-AD. As you might expect, this is an older patient population with lots of comorbidities. Slight majority were males, a broad range of renal function from totally healthy kidneys to basically shut down kidneys. Now, those at the lower range of this creatinine clearance, you would expect had that develop acutely, because if their creatinine clearance was that low, they would never have been on dabigatran in the first place. Broad range of doses of dabigatran being used, and most of these patients were, in retrospect, according to the reference lab, anticoagulated at baseline. But remember, these patients were all reversed based on clinical grounds, not because of any lab test. Here you see the primary results of REVERSE-AD. This is a complex slide, so bear with me. On the y-axis, you see the dilute thrombin time. On the x-axis, you see time. On the left is Group A, the bleeding patients. On the right is Group B, the non-bleeding pre-procedural patients. This is a box and whiskers plot. You see the dotted line going across parallel to the x-axis. That's the upper limit of normal of the dilute thrombin time. So everything above that is anticoagulated. The box represents the 25th to 75th percentiles of dabigatran concentrations, which correlates directly to dilute thrombin time. The line in the middle of the box is the median DTT. Then the whiskers above and below the box represent the 90th and 10th percentiles, and the dot above and below the whiskers represents the 95th and 5th percentiles. The big green arrow that you can't miss is where 5 grams of Idarucizumab was given to each patient. And so what you see is prior to reversal, there's a broad range of dabigatran activity that was anticoagulating these patients. After reversal, after that green arrow, you see a couple of very important things. One, you see all of the variability go away. And that's because the 5 grams of Idarucizumab is really an overwhelming dose for the amount of dabigatran that these patients had. And secondly, you see that it stays, for the most part, out to 24 hours. It stays below that upper limit of normal, the dilute thrombin time. And so there's a persistent effect, a very rapid and then a sustained effect to reverse the anticoagulant effect of dabigatran. And I told you what the primary endpoint was. It was met 100% of the time. The median maximum reversal within 4 hours was 100%, with confidence intervals of 100 and 100 for both the dilute thrombin time and the occurrent clotting time. So Idarucizumab is a very effective reversal agent for dabigatran, a great drug you shouldn't have to use very often. A little more detail on the subgroups. Group A, those patients in whom bleeding could be clinically or radiographically assessed, and that didn't include any of the intracranial hemorrhage patients. The median time from reversal to physician-reported cessation of bleeding was about 2.5 hours. Now, that's not Idarucizumab. Remember, Idarucizumab doesn't stop bleeding. That is Idarucizumab facilitated hemostasis that the physician then provided. The patients enrolled in Group B, the ones who were not bleeding at the time of enrollment, but needed a procedure that couldn't safely be pursued unless the patient was reversed first, had a wide variety of acute pathologies, and these were sick patients. These were not a convenient sample of patients taking dabigatran who needed a catheter placed. These were patients with acute abdomen. There were patients with Fournier's gangrene, patients literally who needed heart transplants, patients who had septic bellies. These were really sick people, a lot of open fractures that needed to go to the ER right away. And in those patients, the median time from Idarucizumab administration to the procedure for which the patient was being reversed was about 1.6 hours. And the clinician-reported perioperative hemostasis with these patients was graded as normal 93% of the time. And in the protocol, the criteria for normal was as if the patient had never been anticoagulated. So again, very, very effective reversal of dabigatran, not a hemostatic agent, but taking the anti-hemostatic agent away. Now, as we talked about, you don't want to just reverse people willy-nilly because you put them at risk of post-reversal thrombotic events. You see here the thrombotic events post-reversal in reverse AD, and the numbers were low. The highest number you see there is at 90 days at 7.4%. The 30-day post-reversal thrombotic event rate was right around 5%. And in almost all of those patients, no antithrombotic protection had been provided post-reversal. So there's no evidence whatsoever that Idarucizumab is a prothrombotic agent. And if the patients were well managed after reversal, since they were stable, put back on antithrombotic protection, then the likelihood of a thrombotic event was quite low. Mortality rates were not so low, but this reflects the fact that these are old patients. Remember, the median age was almost 80. Who have acute insults, life-threatening hemorrhage or a surgical procedure that can't be delayed. This is a bad situation. And so the mortality at 30 days among the bleeders was 13.5%. Among the non-bleeders, pre-procedural patients was 12.5%. But this was universally related to the underlying pathology. These weren't deaths by bleeding. So that's a great option for patients who are taking dabigatran and rarely need reversal. If your patient who needs reversal or repletion is taking dabigatran, then Idarucizumab is state-of-the-art. If your patient is taking a 10A anticoagulant, apixaban, edoxaban, or rivaroxaban, then you should consider use of the recently approved Andexanet alfa, which is a specific reversal agent for those patients. In the Annexa-4 study, it showed a good effective hemostasis achievement rate, above 80% in these patients. It's really effective against all of the 10As, whether oral or parenteral, and has similar safety and efficacy as other approved reversal agents such as Idarucizumab. So in the meantime, focus on the agents you have in your armamentarium. Remember, these are very effective agents that aren't used very frequently because, for the most part, DOACs are a very safe approach to anticoagulation. So I'd like to thank you very much for joining us. I hope you found this activity to be worthwhile. Please be sure to fill out the evaluation so that you can get your CE credit, and look back often on the site for other educational activities.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/NKJ. This activity is supported by an educational grant from Portola Pharmaceuticals Incorporated.